So I had this guy, he was giving some kind of presentation, and he was trying to use an analogy, and the analogy was this. And I don't even remember what the analogy tied to anymore, but the analogy was, so you know how when a guy falls out of a plane? And first off, like that statement right there, like, no, I don't. You know. Are people falling out of planes? But anyway, this apparently in this story falls out of the plane, and he goes, and what happens is, like, this is like, I don't know. But he goes, what happens is that when you fall out of a plane and you hit the ground, the first impact doesn't kill you. It breaks all of your bones, and then you bounce up, and then the second time you come down, it kills you. And I want to know want to know how they did that research. Right?
He's
like, what?
All right, Gary, you jump.
We got to measure in between though. Measure them. Is he dead? So
if I can design like an airbag-like device that stops you from hitting the ground the second time. So like you hit, it breaks all your bones, you bounce up, and then all of a sudden it's like, and you land, you'll survive. All your bones will be broken, but you'll survive with that knowledge. That's what you would have to do to be able to measure if that person was alive between. So somehow he's claiming that there's research out there that shows that someone is still alive when they bounce back up. First of all, how many case studies are there? It just doesn't make any sense at all. This is like you just show up and it's just a splat. First of all, if you ever actually seen someone fall from a height, it's not just like a body with broken bones. It's a splat. But anyway, you show up and you just see the splat and you're like, oh no, it's definitely the second bounce that did that.
Yeah, what? Like, doesn't make any sense at all. So anyway,
that's funny.
Speaking of which, let's talk about patient assessments. This is a good tie-in into our topic today.
Yeah, so interesting topic today and interesting way that we're going to be doing it. So we are going to be doing a VR scenario. So if you're listening to this, I would recommend that when we get to the point, we'll tell you when it's going, like that you at some point jump on YouTube or go to Guardian CME or go somewhere where you can watch the video portion of this too.
And actually on Spotify, you can watch video now.
Yes.
So our videos are also going to be on Spotify.
Yeah.
So you should see it there.
But don't watch something and drive.
Assuming you're driving, don't watch anything, yes.
I don't know. I'm just talking to the few individuals that might be driving their car right now.
Okay.
I listen to a lot of my podcasts in the car.
So do I. Okay.
I watch movies in the car too.
You watch movies in the car?
All the time. Not full movies, but like.
I can't. I tried it before, and I have to watch the screen, which means I'm not watching the road.
Yeah.
So
sometimes I'll be like watching something or like I'll watch a podcast that's a video podcast, and then like I'll realize like I don't really know how I've been driving so well. Like how did I get here? Like I don't really have much recollection of like what happened on the road because that happened passively, but I'm really engaged with on the screen.
Dangerous.
I think it just means my periphery is like spot on or something.
No, I wouldn't put your eggs in that basket.
Yeah, I'm probably the best driver out there. So anyway, we are going to be doing a VR scenario with a little partnership we have with VR Patients. So thank you so much for letting us use your technology. Actually, what's very cool is VR Patients does things a little bit differently. So VR Patients, as opposed to like providing you with pre-built cases, VR Patients will sell their software to educators or individuals that want to build out their own cases using their kind of own unique like UI. So you'll have like a bunch of patients to choose from. You'll have like sample scenarios that you can choose from and then change a bunch and make like whatever you want to happen in that scenario happen. And it's really neat technology. It's pretty immersive.
And this is game changing for healthcare education. Virtual reality right now, is still in its infancy. Like there's a lot of stuff you can't do, but there is so much you can do. And when we talk about like lack of clinical spots to be able to test, the more realistic you can make scenarios, the better students retain. Most VR healthcare education companies out there or who are doing healthcare education, again, to your point, will like pre-build the case. You could pay them tens of thousands of dollars to pre-build the cases that you want, but then you only have those 3 or 4 cases, right? This is crazy cool because now I can go in and I can change, well, what happens to the vital signs when the student does this versus when they do this? There's all of a sudden it's like endless possibilities of people being able to build out clinical scenarios for everyone to enjoy.
And it's immersive learning that inspires experiential learning. So instead of having to go out and make mistakes in the field, you can make mistakes in the VR space. It's so immersive that like that connects to students' memories so much better. Mm-hmm. And then you can be out in the field and experience something and go, you know what, I've experienced this before. Not in real life, but in virtual life, and it was very similar and I know what to do, Mm-hmm. So what a cool, unique tool to start expanding our education with. So anyway, thank you VR Patients for letting us use that. You guys can check out VR patients free scenarios too. We're doing 2 of the 3 free scenarios that they offer for you to sample the product. And I think you get that at App Lab on like Oculus. But if you just search for VR patients on Oculus or any headset, you'll be able to find it. Very cool.
You
stuff.
can also do their cases just on the web too. You don't you can build out. So if you don't have a VR headset, it doesn't mean that you can't still go to vrpatients.com, download their software, and build cases on the web, which your students can then do on the web. They're like a mouse
stop
click
saying
and
on
drag.
the web. It makes you sound ancient.
Online on the World Wide Web on the internet. If you've ever been
on Al Gore's new World Wide Web.
exactly. So
no, yeah, it's cool. So you can do more scenario based, like just on your desktop, where like you move the guy around. It's not like when you move your head, but you can get any view that you want. You can like get closer to him. You can change. I don't know. It's very cool. So a couple caveats with this is VR patients and most VR software right now where we're at, like this isn't augmented reality yet. So we're not like learning how to intubate a patient, but like we're not getting like the feel of holding a blade. Like obviously that stuff needs to be done in a clinic, or it needs to be done in your practicals. You have to get practice doing that. But what VR patients allows you to do is like such a great assessment build. You can really build your skills assessing a patient and be able to look at those things and go through the list, which is why we wanted to tie this to an assessment CE. So that being said, if you are a paramedic, EMT, MFR, IEMT, anything like that, pre-hospital providers, you guys can get a free continuing education credit by listening and watching this podcast at guardiancme.com. So check that out, www.guardiancme.com. And you can watch this episode and take a quiz and get some credits for it, which is awesome. So before we jump into...
For free.
Yeah, it is free.
For free.
Yeah, I guess I should probably say that more often.
It's like the most important part.
Yeah.
Otherwise, nobody cares.
So before we jump into the cases, we got 2 cases that we're going to do. I'll do one, Chris will do one, and we'll kind of walk each other through it using the assessment. I do want to just kind of break down what the pre-hospital assessment is. And this is a great, like if you're a nurse or you're a doctor too, like this is a really great systematic approach. I very much feel like ACLS, PALS, like those build outs of the systematic approach are nearly exactly marrying what a paramedic assessment is a lot of time, or an EMT assessment. And it makes sense, right? Because we rule out life threats first, and then we go into more detailed physical assessments. So just to quickly review that, we're just going to take a few minutes, and then you can watch the scenarios and we'll do a quick debriefing on it. So typical patient assessment, we're going to start by obviously making sure that we're protected. Yeah, BSI, body substance isolation, making sure that we're protected. We have gloves, mask on, whatever we need. Gloves, mask on, that's the first thing that we need to do in every scenario. Then we want to determine that the scene is safe before we approach, right? So we're going to make sure that there's no hazards, there's not an electrical line sitting there, there's not a fire, the guy's not in water, and I don't have equipment to rescue him, right? So we determine the scene safe, and then we wanted to just kind of quickly, in our mind's eye, I always like to call this like initial scene size, sort of like the door assessment. We can do this from the door, before we have approached the patient even. Just try to determine the mechanism of injury if they're injured, or the nature of their illness if they're ill, right? So if they are lying at the bottom of the ladder and you see blood spurting out of their neck, the mechanism of injury is probably they fell from that ladder. But we know this is a trauma case. Or they got
stabbed underneath the ladder. You don't know.
Scene safety.
Scene safety.
That's what we check.
I would look for criminals.
Exactly. So, or the nature of illness. So if I have someone who's, tripoded, clutching their chest and breathing heavily, I know that might be a respiratory or a cardiac thing, right? So we can get kind of a general idea. That's your gut feeling of what's going on. Determine the number of patients. Obviously, that's going to come with the territory there. And then request additional help if necessary. So if I have 5 patients, I'm going to call people. If it looks like an advanced trauma and I'm a basic, maybe I need to call for a paramedic to help out. Or if I'm a nurse and I walk into a room and there's someone on the floor bleeding, I might want to hit that call button and get a bunch of nurses in there to help me out. So next, what you want to do, consider stabilization of the spine. Why are you looking at me so intensely?
Sorry, I was just picturing, because I'm picturing the paramedic scenario where he gets on scene, he or she gets on scene. He's like, oh my gosh, there's 5 victims here. But then I picture this nurse walking into a patient's room being like, why are there 5 patients in here? Anyway, sorry, go ahead.
Okay, cool. Consider stabilization of the spine. So whether they had a medical issue or a trauma issue, recognize that if they are positioned on the floor in an awkward situation, it might be both. I might have had a heart attack and then fallen over. My hip might have broken and then I fell over and I smashed my head. And then I started having trouble breathing.
That's a very paramedic specific, first responder thing.
I disagree. If I walked into a room and one of my patients was laying there, I would stabilize their spine.
I guess I'm thinking more on the doctor side. Like I don't.
Listen, you live in this cushy world where all these other providers fix things up for you, and they're sitting nicely on a clean bed for you, waiting, all packaged up.
I'm gonna be honest with you. My door assessment would be clearly my nurses didn't do what they needed to. I'm gonna have to go talk to them before I treat this patient. I don't do that.
I hope not.
I don't.
I don't think most do.
No, I don't think so either.
That's what I'm going to say, at least to make
old school way of treating healthcare people. You know?
Yeah.
I think sometimes the roles are reversed a little bit.
What?
Like I think sometimes the nurses walk in the room and then they come out and give me a lecture. I feel like that happens to me a lot, actually,
because you need one. Right. So, okay. So anyway, we consider stabilization of the spine, whether it's a medical or a trauma. We just want to consider that. So then you start your initial assessment. Your initial assessment is going to be your life threats, your ABCs. Right. So ABCDE is what we do now. So if you take an ACLS or PALS, like you should be very familiar with this assessment. So
airway.
First, verbalize your general impression of the patient. So your general impression is like, do they look like crap or do they not look like crap, right? And we do this in ACLS and PALS too. Your general impression is really important because you want to have an idea of like, does this seem severe or not right off the bat, right? Mm-hmm. That gut feeling, like we can't really like scientifically describe that, but it is important to recognize your intuition as a provider. So we basically want to know.
This is another cool thing about VR and like VR patients though, is that seeing patients in a certain, like looking a certain way in VR, like all of a sudden like adds to your repertoire of like how many patients you've seen. Maybe you just saw them in VR, but it's still like you saw a person tripoding, you saw a person unconscious, you saw like it may not be full reality, but like it gives you these like scenarios to look back. Like I remember when I had that case and like you didn't, but you did. That's what's so cool about it.
Well, that's what like it is the natural progression of education. Like any narrative question, I would argue, would be better in a VR scenario.
Yeah, absolutely.
Any narrative question. So, because like there's ways to kind of like cheat with the narrative stuff too, where it's like they only gave me the information that I need to know to solve the question. So like I have limited information, but that actually helps me zone in on it from a test giver perspective. And I'm going to go off on a tangent here about education, but from a test giver perspective, it's better to give someone a VR scenario because then there's a bunch of factors they have to consider and they have to narrow in on what I'm specifically asking them about it. Something to think about. Anyway, moving on. Initial assessment. Verbalize the general impression of the patient. Determine their level of consciousness or responsiveness. Hey, are you okay? Are you okay? Think back to CPR. Hey, are you okay?
Like you
are
walk
you okay?
in. Wow, Miss Jones, you look like crap. She doesn't get mad. Maybe she's not.
Maybe she's unresponsive. Got it. Determine the chief complaint or apparent life threats. So this is where like if their ABCDE is like taken care of, you don't see that at a glance. You can be like, "What's your problem? Why'd you call?" Right. Mm-hmm. But then apparent life threats are going to be your ABCDE. So airway. Mm-hmm. What do we want to know about the airway?
Is it patent?
Is it patent?
Patent.
Have we patented the airway?
Patent.
Do we own it?
No, patent.
But if you think about it, do we own that airway is a good example. Yeah, it's pronounced patent. It drives me insane that people call it patent. Patent is something that you get when you're an engineer. Stop it.
Just knock it off.
Patent. Is the airway patent just means is it open? Is it cleared, right? What if it's not? So in the initial assessment, if we ever run into an issue, we fix it right away. So if it's not open, what do we do?
Patent it.
We open we open it, right? So we can do this with just manual maneuvers. We could drop an OPA or an NPA. We could intubate them. We could do all sorts of things.
Jaw
right?
thrust, chin lift.
You got it. So open it. Breathing. Are they breathing or not? Mm-hmm. How are they breathing? So we want to know, is it too fast? Is it too slow? Is it shallow? You know, what's the quality of the breathing? And then what can we do about that? We can right away, if they're not breathing, start breathing for them with a BVM and drop an OPA. We can, start pacing up their respirations or pacing down their respirations. We can put them on oxygen. We can do things right away to fix that, right? Mm-hmm. And again, we don't have to necessarily like fix that whole problem before we can ever recognize that they have circulation or anything like that. This is all happening kind of simultaneously.
Addressing the issue is different than fixing it. Like you don't have to wait for it to be fixed, but you need to address it. So if I put oxygen on you, I'm going to address the issue. I should reassess. Reassessment is always a key piece, right? But I can also probably move on.
And that's where like this argument gets into like with the CPR assessment, we switched it to like CAB versus like ABC. And it's like, it doesn't really matter, guys. Like you should be able to do these three things at once. Like that's where assessment and doing VR scenarios and things like that will help you become practiced in. I can have multiple pieces of information coming at me at once and handling multiple issues at once. And that's something that you have to kind of breed into yourself. So next would be circulation. that includes like controlling major bleeding, right? That's a circulation issue. So if there's like blood spewing out of them, I obviously want to get some hands on that, gloved hands, because we already put our BSI on, gloved hands on that, get some pressure on that, try to control that major bleeding. But we want to assess their pulse. We don't just want to check if there's a pulse or not. We want to see, is it going too fast? Is it going too slow? Is it thready? Is it irregular? Like, is this cluing me in that I maybe should get an EKG? And then while our hands are on that patient, we're checking that palpable pulse. We should be checking the carotid, because the lowest blood pressure that you can have, that's not, wow, I worded that terribly.
It's so you're going to lose
you will catch the carotid pulse the latest.
Yeah.
You were about to say way better.
Yeah.
Go ahead.
I think you screwed me up though. No, I was saying you will lose a pulse in the radial, brachial before you lose in the carotid. Right, the carotid is the closest to the heart. So
it's the last bastion.
We go there first, because then we can say yes or no they have a pulse. If they don't have a carotid, their heart's not beating. Right. If they don't have a radial, well, their heart could still be beating. I don't need to start chest. The next decision is chest compression, so we go right to the carotid.
Well, the thing is if they don't have a carotid, their heart could be beating, but it is not beating adequately enough to actually circulate their blood, which means you need to do CPR either way. It's equivalent to just not having a pulse.
But I've done this before, where I go carotid first, and then I'll move down to radial. And then if I don't have a radial, I mean, that's like, oh shoot, this person's like
lower blood pressure,
about to die type of thing. You know what I mean?
Yeah, we used to be able to estimate, and the numbers shift every once in a while.
Or oops, I was on the wrong side of the wrist. One of the two.
We used to be able to estimate, like radial could tell us that they usually have a systolic around 70, and then it was
debunked.
like 60, 50. I think the numbers changed. I don't know if it was completely debunked.
I think
it's like a street cheat. It's not like a legitimate. Also, like, why would you not just take the blood pressure?
Right.
I don't know.
Right.
So anyway,
because you don't need to, because you're so good at feeling the radial pulse.
Just feeling it. Cool. So ABCs, right? We check that circulation. While we're touching them and we're looking at their skin, we should assess their skin. So is it, pale, cool, clammy? Is it red? Is it gray? Is it how's the why can't I think of the tenting? Is it tenting? How hydrated is this patient? Things like that. And then we can go ahead, based on that information, we can sort of decide, what the patient's priority is, right? So if we bumped into an issue in that initial assessment, it usually increases their higher priority, right? So for you pre-hospital providers listening to this, you're going to be thinking like probably a priority 1 patient if like their airway is compromised, right? If you're able to fix that, maybe they're priority 2. It all depends. You're going to have to base that on your training and your local protocol.
And again, when we get into priorities, it's more about how fast do I need to move? Can I stay and do some work? Do I need to get going right away? Do I need to call back up? Do I need to,
triaging is very different for a pre-hospital provider and like the person in the ER who's triaging a patient, right? A nurse triager, at the ER when you first come in they're triaging the patient in terms of like, where do I put them? Pre-hospital providers are triaging the patient in the sense that like, what am I reporting to the radio?
And how fast do I take them? And where do I take them? Sometimes,
exactly.
You know what I mean? Like
exactly. So,
like if Dr. Sykes on shift, maybe we should probably go
a lot of times I would call medical direction. If you answered the phone, I would hang up and I'd go to a different patient.
Oh, that was you all those times.
So then we can move on to a focused history and physical examination or a rapid assessment, depending on what we're bumping into, right? So we want to figure out the signs and symptoms of the patient, and then a history of their present illness. So we want a focused history. I don't care if you got your tonsils taken out when you were, 13. I want to know, like, have you had chest pain before, or have you ever had a feeling like this before, right? So signs and symptoms, we're going to go through that. And then we're going to kind of, in a different way than like a lot of docs will do a full physical exam all the time because they're looking at health a little bit more holistically. We're talking a little bit more about acute situations.
I don't know if we do.
Well, you're an ER doc. Oh, yeah, no, I know.
I mean, like, I feel like if anybody would, it's an ER doc.
Yeah.
Like you mean, because like, but I mean, we do a very focused exam. Like because the cardiologist isn't doing a full exam.
Well, because someone has already examined them and then they focus in on his issue. You shouldn't be relying
on that either, right? Like, you should always do your own exam.
Yeah.
It's kind of a general rule. So, like, technically, I feel like every doctor should be doing a full exam on every patient that they see.
Yeah, but a cardiologist isn't in the same situation that we're talking about, kind of like more of an emergency assessment. Right. A cardiologist doesn't have to walk into a room and be like, are they breathing? Like their job is to work on the heart. Yeah. You know what I mean? So it's like that's a prepackaged patient for them. So you can give them a break, Chris.
I don't know.
This constant battle between ER physicians and cardiology needs to stop. Just collaborate.
All right, fine.
All right. So anyway, then we want to kind of go down the different like pathologies and kind of rule things out. So like, for instance, if they had an altered mental status, we want to start talking about like onset duration, like get an OPQRST sort of thing, get a sample history based on that, and then start tying in ruling out factors from there, right? If they had a respiratory issue, same thing, onset, provocation, quality, does it radiate, is there severity? It doesn't really fit with respirations. I don't know why they have that on here. Like, how does is your respiration issue, is your tachypnea radiating anywhere? It doesn't make any sense.
Yeah, I don't know how that would happen.
Like my butt. It's like, no, you're just farting, dude. So, all right. Then you want to get a basic sample history. So sample is a great acronym. A lot of nurses don't know about sample, which I try to like teach as much as I can. I learned it in pre-hospital stuff. And then as a nurse, I applied all the time, but sample history is a great history taking tool. So signs and symptoms, their allergies, their medications, their past pertinent medical history. Again, I don't care if you got your tonsils taken out. Your last oral intake. So this could be meds or food or whatever. And then E would be events leading up to the incident. Now, we really only use OPQRST to evaluate pain. And that's where I said it doesn't. So like if you have pain, I can say the onset of that pain. So when did how did it come about? The provocation of that pain. Does anything make it worse or better? The quality of the pain. How would you describe it? It feels like a throbbing. It feels like an elephant sitting in my chest, right? Radiation, is it traveling anywhere? Severity, how bad is it on a scale 1 to 10? Again, we don't care if they give us something outside of that scale. We want to know if that number is going down or up. So when someone gives you 11.7, it doesn't matter. Like, don't get mad. Yeah. And then T, time. The difference between onset and time at the beginning of this assessment is onset is how it came about. I was mowing the lawn when I started to have chest pain versus the time is I was mowing the lawn a half hour ago and it's been going on that long.
It's just funny because you said tea time. I'm thinking of like a doctor being like, tea and time. Like at the end of that, when's my next tea time? I need to make sure I got to have enough time to get there. So, okay.
So yeah, we go through that sample history. That's when we can start doing physical examination on the affected body part or system. Or if we don't know it still, then we can do like a rapid full body assessment. We can kind of go through, does it hurt here? Does it hurt here? Check every system and move down there. At that same time, we're doing vital signs. We're going to get some basic vitals on them. And then we can start applying interventions relevant to the situation, right? Mm-hmm. For paramedics, EMTs, pre-hospital, then we would consider our transport decisions. When should we transport and where should we go? And how fast should we be moving? And then, again, what we have in our paramedic assessment, we have like verbalize the consideration for completing a detailed physical exam, right? So at this point, like, have I solved the problem and everything's going well and I have solved the mystery, or do I need to do a more detailed physical exam in these systems, right? And then you have your ongoing assessment beyond that. So you're going to continue to do these things. Repeat your initial assessment constantly. Whenever there's a change in patient condition, repeat your initial assessment. Did they lose their airway? Did they lose their breathing? How's their circulation?
And anytime things change, right? So anytime you do anything. So if I put you on oxygen, I'm reassessing. As I, give you, an aspirin or more, you're reassessing every time you're doing something too.
Yep. So. And that's what it says. Repeat vital signs, obviously, and then repeat focused assessment regarding the patient's complaint or injuries. Here's some pain medication. Do you feel better? You're not just going to leave then, right? Right? So here's some pain medication. What's the pain now? You got to give that time to carry out, which is another unique aspect of VR patients is like you're not going to be able to like give fluid and then instantly see the blood pressure go up. It takes time to do that, and you can program that into your scenarios where it's like it's going to take 5 minutes to see a change.
That's cool.
Which is pretty neat. Yeah. So, all right, cool. So that's the assessment that we're going to be following. That's the basic like patient assessment management for a medical emergency. I think that it can be heavily applied in other medical areas in terms of physicians and nurses using this as well. It's a great systematic approach. Again, that's how we build out ACLS and PALS. A great systematic approach to how to approach a patient. We're going to demonstrate this now for you in our VR scenarios. So, hope you enjoy it. And it doesn't go as I hope it doesn't go as off the rails as it did the first time we did it.
Yeah, it wasn't good.
Which was just me and Chris like laughing about everything in VR because we were so amazed by the situation.
Yeah, it was awesome. So, all right, cool.
Let's check it out, and we'll see you back in here in a second. Your dispatch information was for a female with jaw pain. Go.
That's it? Okay. Well, so this is the first case, right? So we're going to jump in here, and here in VR Patients, I could play to get the case going. So you said my dispatch information was what now? Jaw pain.
Woman with jaw pain.
All right, cool. And go. So the first thing I'm going to do, we went over our assessment, BSI. I'm going to put on my gloves on these invisible hands.
So you can do that in the scenario too.
I can do that in here. Okay, go to assessment. I'm going to, there we go. Look at this, PPE. I'm going to put gloves on. And I'm looking around, and I'm probably going to put a gown, a 95, and a face shield as well. Okay.
Because this bathroom's disgusting.
Right. Good. So BSI, so now scene safety. Clearly, looking around here, scene is not safe at all. I'm gonna leave. I don't understand, where is everybody else? This is a very shady experience. I don't feel comfortable. So I'm gonna call for backup. Okay, so BSI, scene safety, and now...
What is her mechanism of injury or nature of illness?
Okay, so I'm gonna do my from the door exam here, right? I'm looking at her. She's kind of like holding herself, leaning over. She doesn't look like she's very comfortable, right?
Okay.
So I'm gonna basically then go
there's only one patient, right? You don't need to call for any additional help, and it doesn't seem like you need to consider C-spine because she's just sitting there.
Correct.
Cool. So now we want to kind of go through our ABCs.
ABCs, right? So airways patent, like yes, she's moving around here, talking to me. I don't know
you can get down on her level. Yep, there you go.
Oh, yep, you okay? Okay.
Hello.
All right. Breathing. So let me grab my stethoscope here, and so I can see that she's breathing well, but I can kind of listen to her lungs here too. Oh yeah.
Nice. All right.
So breathing's good. Yep. Breathing's good, and she's got a good rate going here.
You can palpate a pulse.
I can palpate a pulse. Let's see.
Should be right there. Yep.
Pulse. Mm-hmm. With these fingers.
So now, if you put it on her carotid, you should be able to feel it.
Yep, I can feel it. Look at it. It gives it to me right here. Heart rate 108. Okay.
All right. So she's a little bit fast.
Tachycardic. It's a good pulse. Can I feel her wrist too? Yes, I can. Heart rate 108. Okay. All right. So airways patent. Breathing seems good.
And then while you're checking that circulation, other things that you're looking for would be like her skin color. Verbalize. It's always good to verbalize that in scenarios so instructors know. Like,
it's a good point. So skin color looks good here. I'm gonna pinch her skin.
You got any tenting, things like that?
Nope. Okay, that's good. And then,
so what's your general impression of this patient? Like,
my general impression that is like she's stable right now. It seems like, as far as I can tell so far.
Yeah.
But something's going on, right? She's a little tachycardic. She's a little tachypnic, maybe. She doesn't look like she's feeling very well.
So we could call this like potentially unstable in an EMS scenario, like we're thinking priority 2 right now.
Sure. So now I'm going to ask her a little bit about what's going on. Patient info? Where is this going?
So you would go to assess. There should be a question.
Treat. I need to find the questions.
Pause it real quick. Oh, that doesn't help you. All right, good. Unpause now.
Oh, dialogue. Here we go.
Yeah,
dialogue. Questions. All right. Okay. So, ma'am, I'm a paramedic with EMS. Can you tell me your name?
Cheryl.
Nice to meet you, Cheryl. How old are you?
63.
63-year-old Cheryl. And who called EMS?
I called 911.
You did. Okay. I want to ask you why.
So you want to know what her chief complaint is, right?
Right. Why did you call EMS?
I just don't feel right. I'm even a little winded.
She's a little winded. She's not feeling right. Okay. Whoa. What is this here? Don't mind if I do. All right. So I've got my monitor here. I'll set that down there. I'm gonna ask her a little bit more. How long have you been experiencing this complaint?
For most of the day today.
Most of the day today. How would you describe your pain or symptoms?
I'm not sure. Somewhat sore or achy.
Very unhelpful. So sore, achy in her jaw, apparently, with some shortness of breath. And let's see, when did it start?
When I woke up.
You woke up this morning?
Maybe 6 or 7 hours ago.
6 or 7 hours ago. Okay. And how would you rate your pain?
6.
So this is a great like OPQRST assessment that we're doing on her pain level, which is perfect. This is all part of a kind of getting a sample history on the patient. This is a demo scenario, so it may not allow us to get like super deep into the sample history, but obviously we'd be asking signs and symptoms. Are you allergic to anything?
I'm going to ask her if she takes any erectile dysfunction medication. She says no.
There you go. Well, that might be useful in this case coming up here. So then we can move on.
So there's a lot of questions here. So I'm getting the general gist, right? Like she's got jaw pain, she's feeling short of breath. Like, okay, this sounds like maybe cardiac related. She's a little tachycardic. So now I'm going to put her on the monitor.
Yeah. And I always like to describe like the secondary assessment is all about like asking questions. It's getting info. There's 2 ways we get info, right? We ask questions and we also look at vital signs and we use tools. Right. So now we can go ahead and run it all.
I'm going to get SpO2, get a heart rate. I'm going to go her blood pressure. I'm going to set it for every 3 minutes. Get her temperature. And it's always just good to get an IQ check so I can get all these things. So now I've got my monitor, I got stuff going on here, so let's take a look. I've got a heart rate of 108, which we knew. Blood pressure 136/88, so that's good. Respiratory rate's 24, so maybe a little tachypnic. Temperature looks good, glucose is fine. End title's 36, SpO2 93%. So really vital signs other than being a little bit tachycardic, I'm pretty comfortable with these vital signs otherwise. So that's good. So I'm then going to probably also get an EKG here, right? So why don't we get a 12 lead? Here it is. All right, taking a look at my 12 lead. We're not going to go in through 12 leads, but many of you may be able to recognize that there's something kind of wrong here, right? So I've got some ST depressions in 2, 3, and where's AVF? AVF. And I've got some ST elevation in V1, V2, V3. And those lateral leads look okay. So this is, and I got some in AVL as well. So this is looking like probably an anterior wall MI, all right? And even if you didn't know it was anterior wall, like I said, maybe you're not as up to date on your EKGs quite yet. We see these big elevations here. So ST elevation.
So we do have septal there too, because
let me pull that back up.
So remember, it's you can tell a big lie, you can tell a little lie. Otherwise, you're not getting any ASS at all. So like you have anterior leads V3 and V4.
You're just gonna throw that out there like it's just like a normal.
Yeah, well that's how we teach them. But okay. V3 and V4 anterior leads, right? Mm-hmm. And then septal leads would be V1 and V2, and that's where we're seeing like the really stark elevation there. Mm-hmm. So, and a lot of times those two areas are caught up in one another. So
sure, absolutely. Cool. All right. So now what I need to do is I'm going to start to treat these kind of symptoms that she's having, right? So I'm going to get first I'm going to put an IV in. We're going to turn this on. We're going to do an antecubital in the left, and we're going to use an 18 gauge, and we'll just do some normal fluid lock for now. Fluid rate, we'll KVO. Volume, we'll just put a 250 bag up. Administer.
It'll pop that up for you. You get a little bag going.
Here's your little bag over here.
Awesome.
All right. So now I put the IV in because I want to give her some treatments here. The first one I want to give her, like I said, I'm thinking this is obviously like it's an ST elevation MI. I'm going to start with an aspirin. So let's pick. Oh, there it is. Aspirin. She looks like she can take oral fine. We'll give her 324. Baby aspirins. Gave that to her. Now I'm also, she said her pain was like a 6, so I'm also going to probably give her some pain medication here. I'm going to try, actually gave her some nitro first to see if that helps.
We double checked her blood pressure. Blood pressure was acceptable to be giving nitro. We're not going to bottom her out or anything like that. So
we'll give her
0.4 usually
of nitro. And give that to her. Now, I can run the blood pressure again if I want.
You have it recycling every 3 minutes, so it should pop up for you.
So it should pop up for
if
me.
It changes.
I might, like I said, no, I'm going to kind of reassess her pain probably at this time too. I don't, like if her pains improve with that nitro, I'm probably not going to give morphine as well. Because again, morphine might also drop her blood pressure a little bit, and I don't know, I need to give this a minute to recycle and tell me how her blood pressure is doing.
Do you have her on oxygen yet, or is that just?
I do have her on oxygen, yes.
Okay, good.
Right there. So we've got oxygen, we've got, and you can see here, so I can pick what I want. So nasal cannula.
Because I think you have end tidal on her, so technically it'd be silly to set up end tidal, not be flowing oxygen to do that at the same time. So
to give you an example, so I can do nasal cannula here, and
yeah,
I don't know, what do you set?
You do like four LPMs.
That's good. Okay,
yeah. Cool. And then I think what you can do is you can do treat and then hit transport. It'll take her over to the ambulance, and you've pretty much covered your.
So this might also be the time. So I might move her into the ambulance now, right? And okay, now we're in the back of the ambulance. Now, as we're in transport, I might do my sample history, right? Ask her about a little bit more about her symptoms, allergies, medications, past medical history, last meal. Maybe start to do a more focused, full physical exam, that type of thing. But yeah, I mean, that's pretty straightforward going through. Why don't we, looks like her blood pressure is still looking okay, so I am going to give her some morphine. We're going to do IV, and we're going to give her an IV push of 4 milligrams. She's kind of tiny. I might actually only give her 2, not 42.
You have 8 seconds.
Wait, Claire, 2 milligrams of morphine. See if that makes her feel any better as well.
Awesome.
Look at that. Did it.
So there's no requirements in this scenario. But this is an excellent opportunity for you guys to get some practice, go through your assessment, practice going through that assessment. You can do this, with pressure or with no pressure. You can put time constraints on it. You can, if you're an instructor, you can build these cases out however you want with whatever criteria you want. You could add trauma into this. You could add other medical issues. It's pretty amazing what you can do with the software. So, but great learning tool, great review of assessment. So my turn. Let me jump in and try one.
Welcome back to the garage. Welcome to your next case in the subway.
It's abandoned and scary. Is the scene safe? Probably not. Someone died over here. We already have a stretcher in, so I'm assuming scene is safe here. So first thing I want to start with is getting my PPE on. So I'm going to put some gloves on. I think I can do that in scenario, right?
Yes, you can. Yep.
Let me walk over here and unpause it. There we go. Oh, it's counting down this whole time. Chris, you told me it was a pause.
It was pause.
All right, quick. We got to catch up. So assess PPE, gloves, goggles, gown, N95. Whatever I want to put on, I want to make sure my PPE is on. Scene is safe. I don't think I need to call for any help. I believe I have an invisible paramedic partner in this scenario that can do some things for me. Now let's go ahead and jump into...
Do something about that.
What? Yeah, so
do something about that.
Initial impression of the patient, kind of my door assessment, not looking great. So we can see that she's like purple. She's obviously like not responsive at this time. So I could come up and in normal life, I would, palpate, or I would do a little sternal rub and see if she's responding to me. In this case, what we can do is we can do dialogue and just be like, ma'am, can you hear me?
The patient provides no answer.
And she can't because she's unresponsive. So that's very concerning. Obviously, I'm already thinking higher priority. I don't think I need to call for any backup because I'm a paramedic crew right now, we'll assume. So we're good to go there. We can handle an unresponsive patient. So let's start running through the ABCs, Chris, unless I'm missing something.
No, I would definitely go to the ABCs at this point.
So ABCs, airway. I think the airway is open. I don't know. Let's see.
That's questionable. I don't know if you can in these scenarios check if specifically the airway is like.
I'm checking her face, neck, chest. Yeah, sometimes, so you could put in the notes here and be like, her airway's patent, like in a face assessment if you wanted to. There's a couple ways to do it if you're an educator.
So let's assume the airway's patent in this case.
Assume it's patent, and then we're going to move on to breathing. So what I would want to do is use my stethoscope and take a listen. Oh, gosh.
Oh, wow.
It's really slow. Okay, so that's bad. She's probably not breathing very well. Oh, you can turn the patient.
What?
And listen to the back.
Oh, you do have an invisible paramedic partner.
Invisible
with
partner.
Blue hands.
So I can listen to the back. I'm like right on the edge of the barrier here. I should probably. There we go. Okay. I'm still at the edge. So I can listen again. Okay, so very slow. That's a problem. We want to do something about that. So right off the bat, because we're in the initial assessment, I can do something about this breathing issue. I probably want to put a BVM on and start pacing up her respirations and flowing some oxygen. So I'm going to go to treat oxygen, do this through a, through a BVM.
Why don't you also throw her on the monitor really quick just so that, let's pretend your partner's doing this just to be able to show. So I think this case will give you, you don't need an EKG right now.
So it's very slow pulse rate. That's concerning, right?
You could palpate that, though. You could palpate that.
Yes, I will. So you want SpO2?
Yeah, I'm just saying. I think we show that
blood pressure. We can start doing 1 minute intervals. Check the temperature and the glucose. Yep. So our partner's kind of working on that for us, right? Getting more information. This is all while we're still doing these ABCs, though.
And all I want to do in having you do that is going to show. Obviously, we felt like her respirator was really low. What does it say on that monitor?
I'm not in the room right where I can.
Sir, are you okay?
Oh my gosh, I warped out of here. What happened?
Go back in.
I'm back in. I just feel like I'm always on the edge. I'm about to hit you.
No, not at all. You're 3 feet away from me in real life.
Cool. All right. So respirations is 8, really bad. Blood pressure pretty low. EtCO2 is high, so we know that she's hypoventilating. Her 86 saturation is a problem too. So flowing that oxygen and giving that through the BVM, that's important. Awesome. Getting that EtCO2 reading will help me too with pacing her respirations correctly, right? So you can already see that we're starting to change here, which is great.
Now let me ask you something. Are you using that BVM correctly?
That guy.
The Phantom guy is. Okay, all right.
That guy is using it. So what we're going to do next is we still need to kind of finish the circulation here. So what I would like to do is palpate that pulse. Obviously, we would have checked this. You can feel this. Heart rate is 58. So a little low. Then we get the monitor, and I took a look at that EKG. We were showing that bradycardia, but it was looking like a sinus. So we want to now kind of move on to sample history is what I get, but do I have anyone who can give me a history? No, right? So the only way I can gather information in my secondary assessment would be vital signs, which we're doing. So we're noticing depressed respirations. We're starting to pace her up. Now we need to start thinking of like secondary factors, like what could have caused this, what can improve it, right? So whenever we have like an unconscious unknown like this on a sketchy subway bus that's empty after hours and no one's around to explain it, you might want to start thinking about things like opioid usage, right? So I think this scenario might be trying to lean us towards that. But what are some other factors that we should consider? We got 4 minutes here, Chris, to talk about like other factors we consider. We could consider head trauma, right? So we could do an assessment of the head, which we did, and nothing came up, right? So I don't see any signs of trauma. But you can, in these scenarios, for instance, like remove the upper clothes and lower clothes just to see, okay, are there any injuries or anything like that, right? So no injuries. We should have done a spinal assessment off the beginning. I did miss that, so would want to check for the spinal assessment. But since he was already on the stretcher, I'm kind of assuming some of that stuff already happened. I don't know. What else can you think of, Chris? We could have a sugar issue, right? We didn't do an unresponsiveness, but we checked the glucose. That's 97. So lots of factors, different things that cause unresponsiveness. But one that we haven't solved for yet is that could there have potentially been opioid use? Because she doesn't seem to be responding super well to the breathing and the oxygenation.
And I'd like to highlight the fact that this is an empty subway in the middle of the night.
And again, empty subway in the middle of nowhere. I'm not saying that like if you're the type of person that likes to hang out in a bed in subways, you definitely do opioids. I'm just saying if you do opioids, you probably have better. So, all right. So we'll go. Let's start an IV on her. We'll go 18 gauge fluid, normal saline, tubing. 10. Fluid rate. We'll just bolus with TKO, so 250 bag. Sure. So we can get an IV going. You can see that over there now. And then what we can do is we can consider giving her some Narcan. So why don't we?
And I feel like, especially with like these types of cases where it's unconscious, unknown, you've got decreased respirations, like Narcan's not going to hurt someone who hasn't been taking opiates. Correct, so this is probably something you're going to want to try.
Yeah, I worked in EMS, I worked in 2 counties. One county is if you had an unresponsive unknown, it was always just give Narcan. The other county was only if they have depressed respirations would you give Narcan in an unconscious unknown. Both are very reasonable protocols for, consider this, go ahead and run that. Run down your protocol and give that when ready. So I can give this a number of ways. I'm going to do intranasal at this time. So that would be like 1 in each nostril. So 2.
Even if you're bagging her though?
Yeah, I mean, good point. I mean, I could also do, the program also allows me to, this is going to like now overdose on Narcan, but you could also do IV, which I believe is what we start with 4.
I always do. Yeah. Some people do less. Some people do a lot more.
IV push, and we'd go slow push of 4. And I mean, you can't technically give too much Narcan. You're just reversing those opioid receptor blockers. So, cool.
All of a sudden, she just stands up and grabs you.
Yeah. So now what we would want to do is we want to remonitor, right? We want to do more. So you can already see that. Well, you can't really see anything. I was hoping that maybe the cyanosis would start to go away in the hands here, but now we would want to probably move her to the ambulance. So now we're in the back of there and we're transporting, and now we want to kind of continue our ongoing assessment. This ambulance is the size of my garage. So we want to continue.
There's a lot of space. There's a lot of space in this ambulance.
So we go back to vitals. We get another EKG. We go ahead and
what's nice about these cases is that if you're building them out your own in VR patients, like you can have the vital, like, I don't know if in this case her vital signs end up changing or not, but like you can make them change and things like that. So
so we now have her at SpO2 of 100, so they're changing for sure. Through that oxygenation, we crank that up, which is great. We can recycle a blood pressure and see if it changes. It all kind of depends on if the programmer in this demo case decided to put that in. But let's go ahead and like take the blood pressure now. She's she's pointing at me. She's getting combative.
Oh, wow.
So then this can happen, right? So we took away her high, and now she's getting a little bit antsy and angry. So she's like moving around. That's amazing. This didn't happen last time we did the scenario.
We did it wrong last time, apparently.
I de-escalated her, I think. She's
or the Narcan wore off.
Yeah, that could be true, too. So 87/63, still low. ETCO2, I really think I'd be seeing a little bit better with this pacing of BVM.
You put her on a saline lock, I probably would give her a bolus of fluid.
Yeah, let's do that. She is hypotensive, isn't she? Good call. Oh, she's making some noises, getting fussy. You see that? Do you
Yep.
hear her too?
She's strangling your
Yeah, so
paramedic
like, stop
partner.
doing the BVM, dude. She doesn't like it. Take it off.
Maybe switch her to a non-rebreather.
Interesting. This is cool.
Yeah.
So we could like reassess airway then and everything.
Give her some morphine to
I
calm
want
her
before
down.
the 19 seconds is up. I want to try to get a bolus.
Maybe give her some morphine to calm her down.
Change it.
Just give her opiates, give her
opiates.
Narcan.
No, that's
Gotta
probably a
find
bad
that sweet
idea.
spot.
So it looks like you can change it and you can switch like still want the antecubital left and then 18 gauge and I have 3 seconds, normal saline, and I would choose a bolus this time and I win.
you won.
Success. She looks great. No, so very cool. I did not see that last time. So I wonder if giving the Narcan we didn't have enough time in between. You know, Chris?
Well, and
So-
you could see in the case where like it didn't change right away.
Yeah.
But within a minute or so, it did change, which is
just
kind of
like
cool.
in real life.
Yep.
All right, let's leave.
Where are you going?
Let's get out of here. Let's open the doors. Kinda
just
get
jump
a
out the
peek
back.
outside. You can kind of get a peek of outside, and it looks like it's evening.
Yep.
Very cool. So awesome.
You
Wonderful
open up the
tool
back of
to
the
practice
ambulance,
your
and now you're
assessment.
in Grand Theft Auto.
That's what I want. I want to
That would be
start.
great.
Let's start tying this to other games. Let me bring an actual dude in. Well, look how bad those feet are.
Oh wow.
Yeah. Like, let me bring a dude in after Call of Duty, after I shot him in Call of Duty, and then patch him back up just to shoot him again in the stomach. And it's like I get double points for it.
That'd be really cool.
I wonder how. Yeah, you can like. These piglies are looking rough.
Gosh.
All right. So yeah, VR patients,
Awesome.
very cool. Good review of some assessment and going through our primary, secondary, and ongoing assessments. And now Chris and I are gonna do a little debrief and talk about how we felt.
So how did you think that went?
I think it was good. I mean, I think I think you can see there's always those nuances in any new technology thing too, right? Like figuring out where the next button is to click and move things over.
Yeah.
But it does give you such a better. It's way more fun. It's way more fun to learn in that way. Like to actually see it and go through it, and like I think students retain things so much better when they have to. It's one thing for me to sit with with my instructor or whatever and be like, and I would do this next, and I would do this next, and I'm just reading off a list in my head. But to actually, in some ways, have to do it, you know what I mean? Like that is the retention rate of that is going to be tremendously higher.
Right. And that's what I think, like, it's so easy to sit there with a sheet of paper and go, okay, and then I, check a pulse. Like, forcing you to do that, especially when you've solved the mystery in a case. Like, I think a lot of times in education, we are just trying to get to the bottom line. Like, what case is this? What in this narrative? What are they trying to get me to? Or like in this VR scenario, what are they trying? Okay, it's a chest pain call, or okay, it's a Narcan. It's a I need to administer Narcan, and then you're like, great, I can be done now. And it's like, no. Like, you need the practice and going through every step, because that's where the nuances come in, and that's where things are going to change. You need to be adaptable, and you need practice doing all of these steps. So from an educator standpoint,
I
it's
run
awesome.
into that a ton. I mean, like even as a physician, like I know how to do a systematic exam. Like I know how to do. I've done hundreds, if not thousands, of the. I mean, like, but when to your point, like you get to the diagnosis, you're like, all right, cool, and then you're like, I didn't listen to your lungs.
Yeah.
Especially in VR, and one of some of the stuff like you would do in person because you're there doing it, and in in a VR type or like in even a augmented reality, like when you're doing simulated training, it's not as intuitive to like, oh, now I need to check the lungs and stuff like that. But that's actually a good thing because it forces you to slow down for a second and actually, because I'll be honest, there have been times where like I walked out of a patient's room and went, oh crap, I didn't like listen to their lungs. I went through the whole like their HP, their history. I did a physical, but like I didn't like. And then I come out and then I'm like going to write my note and then like lung sounds. I'm like, well, crap. You know what I mean? Like it's easy to fall back into like, oh yeah, I already know what you have. You know what I mean?
Yeah, as you become an expert in something, you can have a tendency to start abandoning the basics of that assessment, and like that is something that like every provider should be doing every step every time, and we forget that because we think like, well, I know this. You know what I mean? I know this stuff. And it's like, no, you have to be able to do step by step and like define that.
It's easy to lose the habit. It's easy to lose the habit. You know
and I think that simulated training and VR training, as a form of simulated training, forces you to develop those habits well because forces you to do it. It's not going to let you move on until you're through that next part. So,
well, what is great about this is that like with VR patients is like even those cases you saw us do, we could go there are hundreds, if not thousands, of other scenarios. Like you can make the blood pressure do something different. You can, in doing so, I wouldn't say test, but you can train on different things. So it could be the same scenario, but maybe this time I want to focus in on what would happen if I didn't do one piece, or what would happen if I did this extra thing, or what would, you know what I mean? Like you can really start to build these things out and create the patient scenarios. What also is really cool about this too is I think about this as a physician, how many times I see a patient in the emergency department and I'll learn something new, and then I'll go share that with a colleague and be like, oh my gosh, I had a case like that one time too. How cool would it be if every person could see every case that has been seen, because it's then gone and been built out in VR, right? That would be super cool, right? Now I can go and I can go find these interesting or different or like rare cases and then like point people to them. Be like, oh, hey, like this happens all the time where we're sitting down as healthcare providers, like, oh, I saw this crazy case, blah, blah, blah. And be like, oh, wow, that must have been so interesting. Like, oh, I was like, hey, you want to go do it? You want to go jump into I built it in VR. Why don't we go just like do it together and I'll show you what, like, that would be, that's what a cool thing we can do in healthcare education to be able to like, I mean, obviously you can see how that helps everyone. It helps every practitioner get better. It helps every patient in the sense that like, we see things that we wouldn't normally see. Now you're not reliant. What's crazy about this in this kind of digital world is now we're not reliant on our own experiences and building up that the years of practice. And now like you're an older physician, you're like, oh, I've got all this stuff to pass on. Like, what if it could be passed on immediately as part of initial training? What if I could see all these cases before I even saw a patient in real life?
My experience can become your experience.
Yeah.
And if you think of that too, like the multifaceted approach of like, if we did interdisciplinary care too, like now a paramedic can see what a nurse is doing with that patient later because they can jump in and see that scenario. Now a nurse can see what the doctor did with it. Now the doctor can see the initial doctor can see what the specialist did. And so you can start looking and seeing this like more holistic care and seeing all the facets of it so that you can increase your understanding. So much of what we do on this podcast is taking basics, breaking them down and showing you the different facets of it, right? This is another tool to be able to do that. So I will say, like, if you guys liked this VR approach, like we may do other, CMEs or just, video casts doing this if it's something that you guys enjoy. So please like comment, send us a message, do what you got to do. Let us know if you liked it because we're certainly willing to do more. And VR Patients has been gracious enough to let us play around in their software.
And
so
maybe we'll start a sub channel. I just had this thought. You ready? We start a sub channel. No.
Let's just talk about your delusions of grandeur in the psych episode.
Yeah, here it comes. We start a sub channel where you guys as listeners can write in cases that you had. We'll go build them out in VR Patients and run through them. That'd be pretty cool.
That sounds like a ton of work for Jason.
Well, but it'd be really cool.
Yeah.
So
we might not. We'll just keep that in mind. But first, let's just start with send us some comments, send us some emails. Let us know if you liked this, if you want to see more of this. And
we'll start there. I'm like, and Jason will go build out all your cases. All right, perfect. Awesome. Well, thank you guys for tuning in. We will see you next time.
Stay sweet.
Hey guys, thanks so much for taking a listen. If you are studying for the National Registry exam, we're here to help. We have a National Registry prep program to help you pass that exam. Check us out at guardiantestprep.com. If you'd like continuing education credits for listening to our podcast or watching this on YouTube, follow us at guardiancme.com. 100% free CAPC credits. No matter what state or country you're in, we're here to help. So again, we thank you so much for listening. We hope you have a wonderful week.